Good afternoon, everyone. This is Sherene Loy, and welcome to today's online VCCC breast cancer round. Just to remind everyone that this is a fortnightly event showcasing the latest developments in breast cancer-related research locally, nationally, and globally. I would first of all like to acknowledge the traditional custodians of the lands on which myself and today's presenter is located. I would also like to pay respect to elders, both past, present, and extend that respect to other Indigenous Australians present online. Now, quickly, we just have to welcome everyone to today's presentation, and in accordance with our COVID-19 precautions, the breast cancer grand rounds will be available only through webinar until further notice. So please check the VCCC website for upcoming events. If you have questions today for today's presenter, you can do this through the GoToWebinar platform. So please do put your questions through and we'll try to answer them at the end. So today it's my pleasure to introduce Associate Professor Elgene Lim, who is a medical oncologist at the Kinghorn Cancer Centre at St Vincent's Hospital. He leads the Connie Johnson Breast Cancer Research Group at the Garvan Institute of Medical Research. He's a clinical academic at St Vincent's Clinical School, University of New South Wales, and is also a National Breast Cancer Foundation of Australia endowed chair. His team performs clinically focused lab research, utilising patient-derived breast cancer xenografts for the evaluation of novel therapies. A major focus of his group is overcoming resistance to currently used endocrine therapies. His research is funded through the National Breast Cancer Foundation, Cancer Council of New South Wales, Cancer Australia, NHMRC, Love Your Sister, and the Garvan and St Vincent's Clinic Foundations. Just briefly, he was awarded his medical degree through the University of Melbourne and obtained his medical oncology fellowship through the RACP in 2006, his PhD next door at the Walter Eliza, and he furthered his research and clinical training at the Dana-Farber Institute and Harvard Medical School in Boston. He was awarded a National NHMRC Scholar prior to returning to Australia to establish his own research group. So today, Elgene will present to us novel approaches on overcoming endocrine and CDK4 and 6 inhibitor therapy. As many of you know, that these treatments are standard of care for current breast cancer patients, and we look forward to your presentation, Elgene. Go ahead.
Thanks, Sherene. How's that? Is the screen coming through?
Yeah.
Yeah, it is.
Wonderful. Well, thanks for the invite, Sherene, and it's a pleasure to speak to you all today. The title of my talk is Novel Approaches to Overcome Endocrine and CDK4/6 Inhibitor Therapy Resistance. So ER-positive breast cancer has probably undergone a recent renaissance in terms of therapies. It was probably the poor cousin for a long time, where a lot of the exciting developments happened in the HER2-positive and triple-negative space. But more recently, a number of targeted therapies have really made a difference and impact in the treatment of metastatic ER-positive breast cancer. And this is just a simple graph showing multiple trials over time, and just looking at specifically changes in outcomes with first-line therapy for ER-positive breast cancer, metastatic breast cancer. And as you can see, you know, in today's standard, a combination of an AI plus a CDK4/6 inhibitor, 2 tablets have really increase the median progression-free survival by approximately 10 months compared to endocrine therapy alone. And this is really now the standard of care. However, excuse me. However, there is little known as to what we should do once patients progress on this very effective gold standard therapy, combination therapy. There is limited data on the predictive biomarkers of response for these 2 drugs. And currently we know that it's ER and RB are the 2 most useful biomarkers, but nothing really beyond that. And there's really very little preclinical data as to what to do beyond that, because models are often restricted to 4/6 monotherapy alone. And really, in the clinical context, we actually see dual resistance to the combination therapy. So these are questions that are ongoing. What should we do on progression? Does progression on CDK4/6 inhibitors affect response to subsequent therapies? Should we continue the endocrine therapy or the 4/6 inhibitor therapy on progression? And how do we incorporate new endocrine therapies? So this, this is a recent study by Surat Chandraparty's group in Memorial, where they looked at about 350 patient samples of patients who've received CDK4/6 inhibitors. And then what they've found here is essentially the genes that are associated with worse outcome. And there are two outliers here, RB, which is what we already know. But I guess what's interesting about this particular study is another novel gene that they found called FAT1, which is involved in a Hippo pathway. And the loss of FAT1 results in increased CDK6 activity and expression. So as a result, these are two genes that are perhaps known in this current point in time to be associated with CDK4/6 progression on CDK4/6 or CDK4/6 resistance. And here is, as you can see, a number of genes that may be associated with resistance, but really making no impact on the progression-free survival, such as cyclin D1 amplification or PI3 kinase alpha mutations. But certainly RB loss is associated with a poor outcome. So in our lab, we're particularly interested in the 4/6 resistance space. And together with collaborators, Liz Keldon, what we've done is establish a suite of models, both in vitro and in vivo. So our in vitro models are based on cell line models as well as mutant cell line models. As we know, ESR1 mutations are common in endocrine therapy resistant breast cancer, and there are now genomically engineered cell line models of these mutations. So with these, what we do is we then chronically culture these with a variety of endocrine therapies, but also with CDK4/6 inhibitors such as palbociclib to generate dual resistance in these models. With our in vivo endeavor, we collect routinely metastatic biopsies from patients who've progressed on their systemic therapies. So in this case, we're interested in 4/6 and endocrine therapy resistance. So we collect metastatic samples or samples from patients who have relapsed on this combination therapy, and then implant them into immunocompromised mice for the evaluation of novel therapeutics. So today, I'd just like to present two stories. Both haven't been published, but both are currently under review. The first one is MDM2 inhibition in combination with endocrine therapy and CDK4/6 inhibition for the treatment of therapy-resistant ER-positive breast cancer. And then the second one is about the androgen receptor as another way of targeting ER-positive breast cancer. So to the first story, we looked at p53 mutations in luminal breast cancer, and this is from a number of genomic databases, transcriptomic databases, Metabrick, TCGA, etc. And we've just pulled out the ER-positive breast cancers in these data sets, as well as metastatic tumors as well, and looking specifically at p53 mutations. Now, it's the most commonly mutated gene across all cancers, and in breast cancer, particularly in the triple-negative and HER2-positive space. But relative to those two other subtypes, it's relatively low. The mutation rate is relatively low, both in primary breast cancer and metastatic ER-positive breast cancer, of about 20 to 25%, and primarily in the luminal B setting. So reactivation of wild-type p53 is an attractive potential therapeutic intervention, and reactivation of p53 may be achieved through inhibition of one of its key negative regulators, MDM2. So how does MDM2 work? So in the subsequent experiments I'm going to talk about, we've used an MDM2 inhibitor called CGM097 made by Novartis, and it's actually been developed primarily in hematological malignancies. And MDM2 works through its interaction with p53 alone or in complex with MDM4, another inhibitor of p53. What it does is it inhibits p53 transcriptional activity and inhibits ubiquination and degradation of p53. So the inhibitors of MDM2 block this interaction with p53, preventing the degradation, and p53 activity is therefore restored, leading to its activities such as cell cycle arrest, senescence, or apoptosis. So we first started off with some cell line models, and fortunately for us, the commonly used breast cancer cell lines, MCF7, T47D, ZR75, actually have an interesting mix of p53, MDM2, and MDM4 status, which allows us then to tease apart some of the unique characteristics based on its genomic characteristics. So as you can see, two of them are p53 wild type, whereas T47D has a p53 mutation, and then etc. for MDM2 and MDM4. So what you can see here is that essentially CGM097, or the MDM2 inhibitor, was able to inhibit the growth of MCF7 and ZR75 cells, but not T47D cells, which are the p53 mutant cell lines. And this inhibition results in a dose-dependent reduction in cell number, but it also resulted in an upregulation of p53 transcriptional targets, such as MDM2 and P21, and it's specific to p53 wild-type models. We then looked at the effects on cell cycle progression and apoptosis, so with across these three cell lines, and once again, you see a p53 wild-type specific effect, where there is an inhibition of cell cycle progression based on BRDU incorporation with this MDM2 inhibitor, as you can see on the figures on the left. And as you can see from the histograms on the right, the addition of the MDM2 inhibitor resulted in increased proportion of annexin V staining cells, indicating apoptosis. We then moved this into ER-positive treatment-naive PDX model to evaluate this in vivo as a single agent. And what we can see in this model, which is also p53 wild type, is that there is single agent activity with this MDM2 inhibitor alone compared to vehicle. It also resulted in a decrease in the Ki67 staining in the tumors, as illustrated on the figures on the right. So what we've shown is that MDM2 inhibition reduces growth rate in vivo, significantly decreases tumor volume, and also reduces the cell proliferation through Ki67. Being sort of ER-positive breast cancer, we're obviously then interested in potential synergies or combinations with endocrine therapy. And there has been literature in the past that show an interaction or intersection between the p53 pathway and estrogen receptor signaling pathway. So what we've done here is then gone back in vitro to look at these combinations with the MDM2 inhibitor with fulvestrant. And once again, what we've shown here is that there is certainly some synergy between the two, where the combination of the two results in a decrease in the growth rate. And there also, on combination index, shows synergistic activity, as shown in the panel in the middle at lower doses. And once again, when you look at the degree of apoptosis, what's interesting to see is there is some slight decrease in apoptosis, but it's not significant with the combination of the two drugs. So perhaps the synergy operates through some other mechanism other than apoptosis. So what we've done to study this is to look at gene expressions analysis of the cell lines exposed to both drugs and alone. And what we can see is that, as you can see from the purple dots right here, there are cell cycle genes that are downregulated with the combination of the two. So purple represents the combination. The blue dots represent fulvestrant. The red dots represent the MDM2 inhibitor, and the gray dots represent vehicle. So there, where there's the greatest suppression of genes are genes related to cell cycle and perhaps some genes related to senescence, but really there's really no significant change in apoptosis versus the MDM2 inhibitor alone. We then looked at perhaps combinations of this MDM2 inhibitor together with other cell cycle inhibitors that are used to treat breast cancer, CDK4/6 inhibitors being clearly one of them. And what we found was that, like fulvestrant, palbociclib does inhibit cell cycle progression, but unlike fulvestrant, we know that palbociclib does not directly target ER, and the combination of MDM2 inhibitors and CDK4/6 inhibitors do synergize to reduce cell numbers in a dose-dependent manner. We next move back in vivo, and this is a particular PDX model that is endocrine resistant. The patient had progressed on fulvestrant. It was a liver biopsy that was obtained from the patient that then went on to establish this PDX model. And as you can see here, that the fulvestrant alone arm behaved pretty much like vehicle, suggesting that the endocrine resistance phenotype continues to play out in the same way in the PDX model as it has in the patient. What we can see here is that the CGM097, the MDM2 inhibitor, has some single agent activity, but certainly in the endocrine resistant setting, the combination has the most significant tumor suppressive effect. And this is just a survival curve on the right. So in this particular model, which is also p53 wild type, but of endocrine resistance, MDM2 inhibition reduced tumor growth as single agent, but fulvestrant did potentiate its action to further reduce tumor growth. We then moved on to a CDK4/6 inhibitor resistant model. And this model was actually established using the previous model and chronically exposing the PDX tumor to palbociclib over a prolonged period of time, which it subsequently then developed CDK4/6 resistance as well. And you can see that here, as through the gray line, the ribociclib and fulvestrant really did not have any effect on the tumor growth at all. What's interesting about this model is that single agent MDM2 inhibitor was effective, which is the red line, in reducing the tumor growth. And the single agent activity appeared more potent in this model than in the 4/6 inhibitor sensitive parental model. So to conclude this first part of the talk, what I've shown is that MDM2 inhibition can be combined with standard of care therapy such as endocrine therapy and CDK4/6 inhibitors, and these synergize or potentiate MDM2 inhibition depending on the resistance context. The mechanisms underlying synergy and potentiation are similar and operate through cell cycle inhibition, leading to senescence, rather than through an increased p53-mediated progression to apoptosis. And I'm specifically referring to the synergy mechanisms here. And then finally, MDM2 inhibition is effective in preclinical models of endocrine resistance and combined endocrine therapy 4/6 inhibitor resistance, and may therefore present a novel therapeutic strategy as 4/6 inhibitor resistance emerges as a major clinical challenge. So how are we trying to translate these preclinical findings? We put together a proposal for a small phase 1 study to find the maximum tolerated dose of this drug, this class of drug, alone and in combination with fulvestrant. So in this particular study, we're looking at the next generation MDM2 inhibitor called HDM201, also by Novartis, and it is actually, it causes less hematological toxicities compared with CGM097, which is therefore represents the way forward with this next generation MDM2 inhibitor. So we've proposed a study with the combination of the two drugs, fulvestrant and HDM201, with a de-escalation strategy as we anticipate minimal overlapping toxicity to evaluate for the dose-limiting toxicities and maximum tolerated dose. And we hope to expand then, once we have this data, to expand the RP2D dose of the HDM201 together with fulvestrant in patients who have had previous exposure to CDK4/6 inhibitors in the advanced setting. As mentioned before, I think P53 wild type status is an important biomarker for this study. So we would also propose to use either ctDNA or tumor analysis for P53 to determine that it's wild type in this expansion cohort. At this point, I'll just switch gears to talk about the second story. What's tying the two stories together is its potential utility in the CDK4/6 resistant space. So just a bit of background. AR is a prevalent target in ER-positive breast cancer. It's expressed in about 90% of ER-positive breast cancers and also in the vast majority of ER-positive breast cancer metastases. And they're actually co-expressed in the majority of epithelial cells in both normal tissue, normal breast tissue, and malignant breast tissue, making cell-intrinsic crosstalk feasible. And this is demonstrated in the histogram on the right. As you can see from the panel, a lot of cells do co-express both ER and PR. And for the older ones in our midst, I certainly haven't given testosterone to women with breast cancer, but certainly some of my seniors have. It was used prior to tamoxifen as a therapy for advanced breast cancer. And in the literature, there was evidence of clinical activity. The only problem there was hirsutism and other side effects of testosterone was really not bearable for most women. And when tamoxifen came by, then it really gazumped the use of androgens for the treatment of breast cancer. There is, however, much controversy as how best to target AR in ER-positive breast cancer. And a number of you would have been involved in trials with antagonists, AR antagonists, as well as AR agonists, all rushing into this space. And they're really conflicting strategies. And a lot of them moved into that space without a lot of preclinical data. So AR, we know that AR protein is prognostic in ER-positive breast cancer. So if AR expression is high, patients have a better outcome with and a 4.8-fold decreased risk in cancer-related death. And it's an independent predictor of overall survival as well. So the hypothesis was that AR agonism is a viable therapeutic strategy for ER-positive breast cancers, and that is kind of what led to this work. This is one of the early data that was presented by Ki-Ming, who was my PhD student and is now a postdoc in my lab. And when we first asked him to look at AR agonist in breast cancer, he first did that top panel up there with MCF7. And it was a little bit disappointing because he said, oh, do I really want to spend the next couple of years looking at this, because there's really hardly any difference, or there's certainly no inhibitory effect in these MCF7 cells. But fortunately for us, we had access to endocrine therapy resistant models, cell line models. So he next then went to test these agonists in the resistant endocrine therapy resistant setting. And really, it's in this setting that, as you can see, we can start to see the growth inhibitory effects of AR agonists compared to vehicle. So in this particular study, which is involves a large number of collaborators, but particularly with Wayne Tilley and Teresa Hickey in Adelaide, one of the first things that we did was to look at the effect of AR agonists on normal tissue. And in this particular case, we've taken breast samples, so both normal breast tissue as well as invasive breast cancer, and then grown them on sponges for a couple of days and looked at Ki67 as a readout in exposure to estradiol or estradiol plus DHT, which is the most potent endogenous AR ligand. And as you can see, the combination of the two, or the addition of the DHT to estradiol, suppresses or shut down Ki67 significantly. Gene expression was then done both on the normal tissue as well as on the breast cancer tissue. And what it shows is that when androgens are given in combination with estradiol compared to estradiol alone, it negatively correlated with gene signatures of cell cycle regulation. So these genes were downregulated, and positively correlated with genes of androgen response when androgen was added, as we would expect. ChIP-seq was done to look at where the AR and ER, where the ER binding sites was affected by the addition of DHT. And what you can see from here is that there are certainly some sites, and the vast majority sites, there was actually a gain in ER and a gain in AR, but there are certainly sites where ER was lost as well. But certainly for the vast majority, when an androgen is given, an AR site was gained, but AR was also shown to associate and modify the ER systrome, or reprogram where ER binds to the chromatin when AR agonist was given. So this is just looking at some ER target genes on the right. And as you expect, when you give estradiol, those ER targeted genes turn up, including MIB and the progesterone receptor. But when it's given together with an AR agonist, a lot of these ER targeted genes gets turned off. And this is just the ChIP-seq just demonstrating the MIB site, one of the ER target genes. And when DHT is given, you can see loss of that binding at the particular site compared to when estradiol is given alone. We next looked at another gene called P300, which is a transcriptional co-activator of ER, and it actually augments ligand-dependent activation by ER. And what you can see on the histogram on the right is that when a DHT, the AR agonist, is given, the enhancer sites for P300 at various genes is actually decreased over time. So what it shows is that AR agonism inhibits the recruitment of P300 at key ER targets cell cycle genes. We then moved in vivo using our PDX models, and we tested this on a number of endocrine resistant ER positive PDX models. The characteristics are listed above. I've just demonstrated 3, but we've done it in far more than 3 models. And as you can see, consistent across PDX models, whether we gave DHT or a SARM. So what a SARM is a selective
androgen receptor modulator. And in this particular set of experiments, we use one called enobosarm, but there's multiple others, other SARMs as well. And what it does is it binds to the AR binding domain. So it's probably a weaker agonist than DHT. And I'll explain further on why we use this clinically. But what you can see here is that regardless of whether we use a SARM or a DHT, there is actually an inhibition of tumor growth in vivo compared to estradiol alone. And in all these tumor models, estradiol drives tumor growth. We just quickly wanted to demonstrate that the opposite strategy, which is the AR antagonist, in this particular case using enzalutamide, really had no effect, and it really behaved very much like control in this particular PDX model. And interestingly, when you actually gave DHT with enzalutamide, it actually potentially inhibited the tumor growth and partially abrogated the growth inhibitory activity of the AR agonist. We also looked at potentially combining an AR agonist with standard therapies such as tamoxifen. This particular PDX model is sensitive to tamoxifen, as you can see from the pink line. It does suppress growth. However, when the important thing to note is that DHT was more potent than tamoxifen as a single agent, which is the blue line. And the combination of DHT and tamoxifen was really similar to DHT alone. So there was really no additive benefit. This is another model that we evaluated this, and in this particular, these treatments, and in this particular model, the tumor was able to grow in estradiol-independent context, so it didn't really need any estrogen to grow. And in this model, once again, we see that the DHT alone had the effect. The antagonist enzalutamide had really no effect at all. So what about AR agonism in combination with a CDK4/6 inhibitor? So this is some in vitro results using our endocrine therapy resistant cell line. So you can see the AR agonist did reduce cell growth and palbociclib alone in this as well in this context. But really where we start to see the most significant cell inhibitory activity is a combination of an AR agonist with palbociclib. We then move this in vivo using our PDX models. So the first model that we used was an endocrine therapy resistant model, not a CDK4/6 resistant model. So in this particular setting, what we've shown is that palbo once again had some single agent activity. The enobosarm had some single agent activity, but really it's with the combination of the two that we start to see almost a tumor inhibitory, or at least a stabilization of tumor volume, whereas the others continue to grow. And this correlated with a decrease in the Ki-67 as well. And then finally, we then try to evaluate this in a PDX model that is resistant to CDK4/6 inhibitors. So this was derived from a patient's chest wall metastases. These are the various therapies that the patients has had before. Importantly, it's both ER positive and AR positive. This patient also had a Foundation 1 test done, and as you can see, it is genomically very complicated. The patient had a BRCA2 mutation, a cyclin D1 amplification, an MDM2 amplification, but also a FAT1 mutation. And I had spoken about FAT1 at the very beginning of the talk as one of those novel genes that are associated with CDK4/6 resistance. So this particular model actually has a FAT1 mutation. As you can see from this growth curves, really the phenotype, treatment phenotype in the PDX model mirrored what the patient has progressed on before. So there was palbociclib had really no effect, the fulvestrant had no effect, and the combination of the two drugs had no effect on tumor growth compared to vehicle. We then added on the enobosarm and palbociclib combinations into this experiment. And what you can see here in this resistant model, 4/6 resistant model, is that enobosarm had some activity, but really it was the combination of palbociclib plus enobosarm that had the greatest activity, or DHT alone. And as I mentioned before, DHT is just a stronger agonist to the androgen receptor than enobosarm, but it's associated with side effects that patients generally don't tolerate very well, whereas the enobosarm is actually not associated with hirsutism. In the various trials that have been run on enobosarm thus far, it's actually been associated with a lot of the positive side effects, such as muscle gain and increased libido, increased energy levels. So it's a much more acceptable treatment for patients if we want to target this pathway. So in terms of the mechanistic summary with the AR agonist story, is that generally this is what happens on the left in ER-positive tumors. So it binds its co-regulators like P53. It sits on the chromatin and it stimulates an ER signaling program that's associated with poor outcomes, including genes such as MYC and cyclin D1. But when you actually give an AR ligand, it does a couple of things. Firstly, the AR ligand, when bound to the AR receptor, when bound to AR agonist, can kick the ER out of the chromatin. Or AR also has some AR-specific activity where it binds directly to the chromatin. It can also increase or use up the interactions with P300, therefore depriving ER of a very important co-regulator. And as a result of all of this, result in good outcome genes being activated, such as the AR program, but also a suppression of ER-driven breast cancer growth. So the conclusions for the second part of this talk is that AR has a tumor suppressor role in ER-positive breast cancer. AR agonist rather than an antagonist strategy is advocated for the treatment of ER-positive breast cancer, even in the context of therapy-resistant ER-mutant disease. That SARMs alone or in combination with 4/6 inhibitors confer potent and durable growth inhibition of ER-positive breast cancer. And as mentioned before, it's well tolerated in early phase trials, but registration studies aren't actually happening as yet. So how do we want to translate these findings? What we've done is put together a proposal to evaluate AR-directed therapy in combination with a CDK4/6 inhibitor in two settings: in patients who are CDK4/6 naive, which is admittedly an increasingly shrinking space because most women in Australia and the rest of the world would now be exposed to a 4/6 inhibitor in a metastatic setting. But also in a post-CDK4/6 inhibitor, where perhaps we can change the 4/6 inhibitor from something like palbociclib or ribociclib to an alternative one such as abemaciclib in combination with an AR-directed therapy and agonist. So at this point, I'd just like to acknowledge the people who've done the work and our various collaborators. So Neil Portman is a postdoc in my lab who's driven the MDM2 project, and Ki-Ming Chia, also a postdoc in my lab, has been driving the AR project. Our collaborators for the MDM2 project are listed there, but I'd like to particularly give a shout out to Yigal and Sue, who may be listening in because they're from the VCCC. And the AR project, as mentioned, Wayne Tilley and Teresa Hickey and Jason Carroll are very, very close collaborators in this work, and our funding agencies, particularly within the National Breast Cancer Foundation and Love Your Sister. Thank you.
Thank you, LG, for that excellent talk. Can you hear me okay? Yep.
Yeah, we can hear.
Great. So we're going to take some questions from the audience, if you can hear us okay. I'll just have a look at if anyone's got any questions, could they please write them in? I've got the first question is actually from Dr. Shom Gold. So FAT1 is proposed to mediate CDK4/6 inhibitor resistance by increasing CDK6 levels. And the question's just got off my screen. God, how do I get this out? So how do you propose, I guess, the mechanism in that context within that patient-derived xenograft, the FAT1?
Yeah, it's a good question. I think we was kind of surprised to find the FAT1 mutation in this model. I guess what we've used this particular model so far for is with AR-directed therapies, and it seems to work in spite of that FAT1 mutation. I think where the relevance of that particular mutation is will be perhaps down to the 4/6 inhibitors' ability to hit CDK, or reliance on hitting CDK6 instead of CDK4. But at this point in time, I guess what we want to do is to have models that reflect what's going on in patients. I mean, we do have a lot of artificial models as well, but to have a model with a clinically relevant mutation and a therapeutic strategy that works in that space is a very useful tool to have.
Yeah, sorry, I've got the rest of the question. Are you proposing that enobosarm can overcome the pelvo resistance by suppressing the CDK6 levels?
We haven't looked at the CDK6 levels in this model, and that's a very good suggestion, Shom, so I'll take that on board. So we haven't actually looked at the effect of the AR agonist on CDK4 and CDK6, but we'll certainly worth considering. Thank you.
Great. So question from Jeff Lindemann. Congratulations, great stories. How important is the status of MDM2 prior to giving the MDM2 inhibitor? For example, there's quite commonly MDM2 amplification. Does that modulate the effect? And also a question that I had was, how often do the PDX models post-CDK or in patients post-CDK acquire P53 mutations or loss as they progress? Do you know some of that data?
Yeah, so I'll answer the first question. MDM2 amplification is actually relatively low in ER-positive breast cancer. So I don't think that that's really a biomarker that we are reliant on. Certainly, we feel that even though the vast majority of ER-positive breast cancer are P53 wild type, this balance of P53 activity can be modulated with drugs such as MDM2 inhibitors, regardless of its baseline level, because the vast majority are not amplified. The MDM4, and I'm very conscious that Yigal, who's a much better expert at this than I am, or than anyone else in the room, it's also relatively low in ER-positive breast cancer, MDM4 amplification. And what's interesting is that it tends to not overlap with MDM2 amplification as well. So it seems to be a different group of patients. But I think our strategy here is really looking at the patients with the wild type P53 status as our biomarker, and really using MDM2 as a way of changing that balance or shifting that balance that is in ER-positive breast cancer. Sorry, can you repeat the second question, Sherene?
The second question is, do you know in patients as well as PDX models, do they commonly acquire P53 mutations post-progression on CDK inhibitors?
Yeah. So the main paper that I would be going back to look at is that Lee et al. Paper in Cancer Cell by Sarat's group. And from memory, there was no mention of P53 being one of the standout sort of mutations that is increased
in the setting of 4/6 resistance. But I need to go back and have a look at that again. Certainly from that figure, which is figure 1 from that paper, you clearly see the 2 outliers being FAT1 and RB.
Yeah, I don't recall any data. Question from Yigal. Great talk, LG. Can you speculate on a possible mechanism of resistance to MDM2 inhibition?
We're not quite there yet. Certainly, I think as a biomarker, we're very, once again, dependent on the p53 status. In our hands so far, both in vitro and in vivo, if p53 was mutant, it didn't seem to work at all. So at this point, that's the only lead that we have.
And do you know if it can arise on an MDM2 inhibitor, the mutation? P53 mutation,
yeah,
sorry.
We have limited models that we've tested this on. I don't know that we have actually looked for p53 mutations in the tumor samples that have acquired resistance. So that's certainly worthwhile looking at, and we might be calling on you to help us with that.
Great. So I guess the question I had was, in your mind, do you think there are differences between the CDK4 inhibitors, Ribo, Palbo, and abemaciclib, given recent clinical data suggesting that, you know, palbociclib was not effective in the early stage setting and abemaciclib was, or do you think that was just a consequence of trial design?
Yeah, I think it's probably both. I mean, I think the Ribo trials, adjuvant trials, will probably tell us how much more of a, you know, is it based on the drug spectrum of activity or trial design. But all 3 adjuvant trials did, you know, include different populations. So it's going to be hard to compare across trials. But I'm pleased to see, I think for abema at least, there is multiple reasons why it could be, and in my mind, abema has always been a different drug to Palbo and Ribo.
Can you elaborate?
Oh, just the spectrum of activity. I mean, you know, it hits other. It's more than a 4/6 inhibitor.
Great. Are there any other questions from the audience? I'll just have a look. Yes. I guess from my point of view, the MDM inhibitors have been quite difficult to develop. You know, with the myelosuppression, they've been very toxic to patients, and certainly we've had trials here that was stopped because of toxicity. So you're hopeful that this new Novartis compound will be more effective with sparing from the myelosuppressive toxicity, or?
Yeah, so it's interesting. I think we, particularly for us who work in the ER-positive space, a lot of times we think of endocrine therapy as a backbone. So, you know, as opposed to other subtypes such as triple-negative breast cancer, where you often or may need a chemotherapy backbone, I think in terms of overlapping toxicities, combining myelosuppressive drugs with endocrine therapy is probably less of a concern. And that's kind of why, for example, our trial or proposed trial, we've opted for de-escalation rather than a dose escalation strategy. But yes, I think this is always a concern with this class of drugs. You know, they've had success in primarily in the hematological space, but they've also had some success in some solid tumors, although very niche areas. I guess our hope is that we can bring a niche drug into relatively common cancer.
And one last question, do you have evidence about male breast cancers, about whether these treatments would be relevant in that context?
Yeah, I think so. It's presuming that question is talking about AR-directed therapies or AR agonism. You know, I think that's a very good question. I've had conversations with colleagues in Holland, which has the largest transgender population in the world. And we've talked about the pros and cons about giving AR agonists, and particularly in the transgender population, they are actually taking exogenous
hormones, and that really complicates things. So we've talked about whether it's safe in someone who's female to male taking testosterone to continue taking that even after they develop ER-positive breast cancer. I don't know that we know the answers. I think this is very interesting and once again also very niche. But certainly there are collaborators of ours particularly in Holland who are working on this area. There's Wilbert Swart, who is from the NKI, who's got tissue collection of male breast cancers of over 100. So I think it's people who have these important tissue resources who can actually answer these questions.
Sure. And one last question. In your current treatment of patients on CDK4/6 inhibitors, if they have oligo progression or small areas of progression, are you inclined to change therapy, or do you treat locally first, or this is just for the clinicians in the audience?
Right. I think, you've got very good people to ask offline at VCCC, such as Sherene, yours truly. So, I don't know that there's a standard answer. I just saw a patient this morning, actually over telehealth. I'm actually at home with the rhinovirus, COVID-19 negative. I had a swab today. Me and my sons are all rhinovirus positive. So I do apologize if I sound a little bit blocked up. So she had oligo progression, and she's got a lot of other disease. I just pressed on.
Yeah, great. All right, so I think that sums up, finishes our presentation for today. I'd like to thank Dr. Lim for his excellent presentation and his time today, and I'd like to thank you all for attending the presentation and for tuning in. So thanks very much, everyone. Bye. Bye, Elgene.
Thanks, Sherene. Thanks.